Good afternoon, everyone, and welcome to our webinar today. My name is Jennifer, and I am an employee at Swope Health, but also with the Metro Council. And today I have the pleasure of introducing our guest speaker. Just to give you a little bit of information about the Metro Council. It's a collaborative membership organization that represents public mental health in the community of the Kansas City metro area. And so the goal is to provide support to member organizations along with education, information, and resources. And there is a mental health KC conference every May, which just took place last month. And then there's also free webinars that are the second and fourth Thursday of every month. So check out Metro Council and all the webinars. And thank you for joining us today. Just a reminder that the views and opinions presented in this presentation are those of the speaker and not necessarily representative of the Metro Council. At the end of the webinar today, I will provide a certificate of attendance link and password in the chat that you'll be able to go and use to print a certificate of attendance. And so without further ado, I'm really excited to introduce our speaker, Dr. Tim Weil, who will be presenting on working with individuals who present with intellectual and developmental disabilities and behavioral health diagnosis. And so he's really going to talk about an overview and some considerations. And so without further ado, Dr. Weil, take it away.
All righty. Thank you very much. Jennifer, can you hear me okay?
Yes.
All right,
Yeah,
great. I'm coming through. I'm always anticipating a little technical difficulty with presentations. But hello, everybody. I can't see you, but I do have my chat up. I'll try to keep an eye over here as well. If you wanted to ask any questions throughout, you're welcome to. As Jennifer indicated, I am hoping to give kind of a high-level view of what we're doing here in the state and working with individuals who are diagnosed with an intellectual and or developmental disability, but also who may have a behavioral health diagnosis or eligible for one. And so want to introduce myself. If I'm able to advance my slides, well, we'll just do it this way. All right, so who is this guy sitting in front of you? I recently immigrated to Missouri from Florida, where everybody else typically goes to vacation. So that was a scene that I saw often prior to moving here last year. I've been the Chief Behavior Analyst here in the state of Missouri since May of last year and have learned a great deal about how Missouri does what it does. I am a behavior analyst professionally. I've done a variety of things. I've been a clinician working with individuals from roughly 3 years of age up into their 60s, a variety of settings as well. I was a professor for about a decade of graduate training in behavior analysis. And, oh, thank you, Michelle. And now being serving in the role of Chief Behavior Analyst. With regards to the Department of Mental Health, we have two divisions. Those divisions are developmental disabilities as well as behavioral health. And when it comes to being Chief Behavior Analyst, the basic roles and responsibilities are that I'm a subject matter expert with respect to human behavior, policy, rules, regulations. I review them, I support them, I educate on them, and I revise and modify them. This pertains to the 4 waivers that we have in the state. I speak to best practice and behavioral supports, and I work with what I'll describe as my Tier 3 intensive supports team to support in crisis and intensive services and support situations. Now, although I am from Florida, I was born in Ohio, I was raised in Florida, and never stepped foot in Missouri until about 2 years ago. And I just absolutely fell in love with this state. So Michelle, thank you for for welcoming me here. And I absolutely adore this state with its geography, with its people, and with the individuals on the teams that I'm working with. So my team, basic idea is that we have a multi-tiered system set up here in the Division of Developmental Disabilities. My team is a multi-tiered system that takes as its foundation a public health model. This is a tiered support framework for population health management within human service settings. The idea is that, as you see on the left here with the triangle, we have 3 tiers that increase in intensity of supports. When it comes to the continuum of care, that Tier 1 level is what we call universal strategies. This is where we have a team of trainers and consultants who work with providers here in the state to establish a foundation of what we would consider positive behavioral supports. You may have heard of PBS in the school setting type situation. That's where it originated several decades ago. However, it is just one example of many multi-tiered systems. So we have universal strategies at tier 1. Again, we have a team that will come out to your organizations, provide training on universal strategies. And it's a requirement of the waivers, if we're working within the waivers, to have a universal strategies curriculum that all staff are trained on. When it comes to tier 2, this is where individuals who are residing here in the state of Missouri who are on the waivers may be experiencing some risky situations. There's a variety that I'll speak to here in just a little bit, but the idea is that we might need to, and we have a separate team for tracking individuals who are presenting with risk indicators and those individuals who may be accelerating or advancing into more crisis or intensive situations, where our tier 3 team, who are primarily comprised of behavior analysts, are available to providers in order to assist with any behavioral supports that might be necessary. One of the things that's really cool about the state of Missouri and about DMH here is that we're shifting from a fee-for-service model, and we really want to embrace this thing called a values-based payment model. Now, why is this important for today? The idea is that we're working on a couple of different initiatives where we're trying to create collaborations between various professionals in the state of Missouri and provide those supports to providers as well as the individuals that they are supporting. Now, in doing this, CMS, who is the federal agency that oversees the waiver, they're very interested in actually moving away from a fee-for-service situation and do more of a pay-for-performance. This values-based payment model, the basic idea behind it is that the better outcomes that providers produce, the more payment that they would receive for those services. I do have a link here at the bottom of this slide where you can see that any information with regards to my team will be here. We have a variety of links as well and supporting documents there. I urge you to check it out. Now, what are our goals when, we're working in the Division of Developmental Disabilities, and I'll speak to this a little bit in a moment, but the idea is that behavioral health and DD haven't typically worked together historically. So when it comes to our goals in DD, we want to fully support individuals. We want to create some kind of supports that providers can rely on, individuals can rely on to create better days, to create better situations, and of course, to try to maximize value in anyone's given day. So our goal is to have, for Missouri to have a healthy distribution of risk among the supported population, for individuals to maintain high quality of life with limited use of reactive, restrictive, and prohibited practices that are being implemented here in the state. Now, those practices are behavior management practices to help orient. And then also our goal is to meet the needs of the individual and the provider organizations to help with capacity and support, make sure that those are aligned. When we speak to capacity, I want to take just a moment to identify what we mean by that. On the one end, when we're talking about capacity, we primarily talk about amount, right? Capacity refers to volume and amount. And so we are looking at how we can increase the number of providers within the state of Missouri. We're also interested in increasing the number of professionals who find Missouri to be as comfortable as I have found it over the last year. And in addition to that, we want to decrease the barriers that providers are experiencing in providing those services. And that's where the rules, regs, and policies come in. Beyond that, capacity is also referring to ability. So I have two avenues that I typically speak to when speaking to capacity. We need more, for sure. We need more providers. We need more professionals in all various areas: psychiatry, behavior analysis, speech pathology, occupational therapy, physical therapy. In addition, we need individuals who are already in the state who might be working with individuals who are neurotypical or otherwise typically developing, to move over and start working with individuals diagnosed with intellectual and developmental disabilities, as well as the co-occurring behavioral health. So capacity refers, as I speak to it today, will refer to increasing the amount, but also increasing ability. And I find that here in the state of Missouri, changing perspective and increasing abilities is the primary important mode of transmission right now, transmission of change, excuse me. All right, so in meeting those goals, our hope is to help an individual stand up, to help an individual walk. And as you see here, to have everything in place that might allow that individual to run. We would want the same for ourselves, right? We would want the same for the individuals that we care about, whether they be family or friends. We want to see people thrive. So what I'd like to do in today's conversation is to talk about leading a thriving life where supports and services are aligned. So when we're talking about populations, in the public health model, we're talking about what is a healthy population. Quickly, before I move on to the next one, I just want to attend to the chat and indicate that I will in fact post the links. And instead of putting it in the chat, what I'll do is I'd be happy just to share this presentation with you all. But if you would prefer them in the chat, I could do that as well. And Lee, thanks for doing that with that first one. Okay, so in a public health model, what is a healthy population? It looks something like this. All right, healthy population is looking at, and what you'll see here is along the bottom of this cube, it says fiscal year 2024, quarter 1, quarter 2, quarter 3, and quarter 4. And so this pertains to what we would expect our healthy population here in Missouri to look like. And the idea here is that with the green, this is universal strategies, everybody's doing pretty good. Roughly 80% are supposed to, of the population, they're supposed to remain within this particular tier. Then about maybe 10 to 15% you'll see in that yellow area, that risk area. There might be a situation where increased risk is occurring because of some change the individual has experienced. And then finally, with respect to that third tier, that top red line, the idea is that individuals in a population that are experiencing the most intensive crisis situations really should be at about 5% at maximum. And again, this model is presented as a public health model. Now, the reason I show it like this, and that you can see that there's a little variation there at the top where it moves a little bit up, there's a little increasing trend and decreasing trend, is that we actually put in our population data with regards to what was happening in quarter 1, 2, 3, and 4. So it went up and down with regards to the total number of population. But when we actually applied our risk indicators as well as crisis indicators, we found that the population is looking more along the lines of this in 2024. We're going to conduct this same analysis now that 2025 is coming to a close, and look forward to seeing in a comparison way what 2024 looked like compared to 2025. In this model, you'll see that we have a pretty good amount of individuals at what we would call tier 1. Universal strategies are working great. They're experiencing good amounts of reinforcement, and they're not showing in behavioral indicators, they're not showing an increase in risk or crisis situations. However, that's still a very small proportion compared to the previous slide. You can see how, like, what 80% looks like right there. When it comes to ours, we're looking closer to about 50%, maybe a little bit less. We see a lot of individuals in the state of Missouri who are on the waivers in a risk type situation. I'll describe those risk indicators in a moment, but the basic idea is that this area, the second tier, is a little bit, heavier than we were hoping to find. And then finally, when it comes to individuals experiencing crisis, we're closer to about between 10 and 15% rather than 5%. So these are actual data from 2024 that show from the waivers. Now, what we look at when we're looking at individuals who whether they are diagnosed with intellectual and or developmental disorders, or they are identified as co-occurring with behavioral health, we have our risk indicators that we can apply. Now, over on the left-hand side, at-risk categories indicating a need for tier 2 level support include 1+ reportable behavioral event in the last 3 months. That just puts it on our radar. We make sure we reach out to the provider our tier 2 group reaches out and says, hey, is there anything that we could do to support you? We see that this individual has had a behavioral event. If an individual has staffing at 485 to 720 hours per month, that is a situation that would indicate that there is a risk problem. If an individual is on 5 to 10 psychotropic medications, we automatically consider that a risky situation, lest they not be on those medications, that at least that many. Is really surprising. Some of y'all in the audience might be shocked to see that there are some individuals here on the state on 10 plus psychotropic medications. I'm going to have the actual number incorrect, but it'll be very darn close. We are roughly 575 individuals in the last quarter on 10 plus psychotropic medications here in the state. The use of intensive group home, that is what we would call the ITRH, or the intensive treatment and rehabilitation. We only have one of those homes at this time. Supports requiring due process. Oh, quickly back to the ITRH concept. The idea is to create wraparound services that are either on-site or at least very close to being on-site, so that individuals experiencing risky situations and/or crisis would be able to receive services and supports quickly. Also, if an individual has moved in the past year or is moving by choice, we just want it on our radar to make sure that both the prior provider has debriefed us and helped us to understand why the move is occurring, as well as the new provider is supported and feels that they are able to move forward with this individual with few, if any, difficulties. At the provider level, we're looking at greater than 50% of their population, of the provider's organization, who they serve. If greater than 50% of that population has at-risk indicators, we are going to make sure that we are working with that provider on an ongoing basis, as best as the provider would like to work with us. In addition to that, risk population remains chronically at risk. Now, when it comes to individuals getting right up there to the tippy top, right up there at the top of the triangle, where we're talking about crisis experiences, intensive services being required, we also have it broken down into person level and provider level. At the person level, we make sure that we're paying attention if an individual, again, has 1+ reportable event, more than 720 hours of added staffing, 10+ psychotropic medications. As I described earlier, we had roughly 570 in the last quarter, and then 1+ hospitalization or law enforcement involvement in the current month. We have a lot of individuals who experience hospital and first responder experiences. Individuals who have had 2+ moves in the past year or forced to move, we would consider a tier 3 intensive supports individual. We would consider a provider organization a tier 3 provider organization if greater than 25% of their population has high risk indicators, or if risk population remains chronically high. So in other words, they consistently are supporting individuals who have difficulties, which is great. We need more of that, as I opened up. However, we want to be there to support them, to make sure that they succeed, to try to stop the cycle of individuals moving from one provider to another, or the cycle of going from the provider into the hospital and then back to the provider, but then back to the hospital again. So we have a variety of situations that seem to be cyclical here in the state that we're trying to impact with my team, what we call the multi-tiered systems and supports. All right, a couple of resources real quick for you all. Time check. All right, great. So we're looking at transcript will be made available. Yes, excellent. So we have resources. MOAD was developed in 2018. It's less vibrant now.
You're back, but you're muted. Okay.
Where
I was like, oh no.
Where did I go? All right, I think we can pick up.
Okay.
I think we can. There we go. Share. Please affirm that you see the presentation again.
Yes.
Okay, great. Sorry about that. I have no clue. All right, so when it comes to resources, we got a couple out there. Thanks for the thumbs up, y'all. I appreciate the support on that. So when it comes to resources, I want to bring your attention to the Missouri Alliance for Dual Diagnosis. This was started in 2018. As I indicated, it's a little bit less vibrant now because other offshoots have occurred. Its purpose was to start bringing us together. And fortunately, we have an excellent chief medical officer named Dr. Angeline Stanislaus, who I have the good fortune of working with. And she has really been a vocal supporter, an energy supporter to DD's desire to bring things together and to work together to support individuals here in the state. I bring this up specifically so that you can visit this website. And this website has a guidebook. I've just printed it out. I'm kind of old school. I like printing. This is the guidebook for best practices with dual diagnoses. And I urge you to check it out. It's a short read, relatively speaking, about 60 pages, and has a lot of good information in it for you. Now, with regards to an offshoot of MOAD, it turned out that Missouri Behavioral Health Council was formed. And the Missouri Behavioral Health Council was born out of these prior efforts and focused on increasing influence on public policy advocacy, community outreach, training and education, and data management and reporting. And so what we see here is that it's a voluntary, the committee members are voluntary members who come together. We call ourselves the BID committees. There's three committees. And our ideas are to bring people together, providers, practitioners, and bring them together so that we can all be in the same room together. Sometimes they're virtual, sometimes they are actually in person. And the Missouri Behavioral Health Council has a variety of things on their website that they advertise with regards to in-person trainings around the state. So I urge you to check them out as well. And I'll share a couple here on the next slide. But I wanted to bring this to your attention so that you could visit with them as well. The educational opportunities are spectacular. The bringing together of different professions is also outstanding. It's an experience where, especially if you're in the same room, you can just feel how excited people are that there's other individuals who are in their shoes. Want to put a little shout out to the conference that is coming up, and I made it spin like that just to make sure everyone's paying attention. But this conference is coming up here, and this is in September down in Branson. They have a pre-conference where folks like me and others will be doing presentations more from the DD side. And then there'll be another 2 days where they have a variety of presentations. And last year's speakers were just outstanding. So I urge you all to go if you can, but at the very least, check out what they got going on. A couple of things they do have going on in the near future are a positive behavior supports approaches for individuals with BID. This is July 17th, and it is virtual. Another training that they're doing on July 24th pertains to conduct disorder, intermittent explosive disorder, and impulse disorder in people with IDD. So check those things out. Everything that you see here is on their website as well. If you have any difficulties with anything, you're welcome to reach out to me, and I'll get you linked up. All right, so what is BID? You know, I've thrown that term out several times. You can see that it's an acronym. Refers to behavioral health, IDD, intellectual and or developmental disabilities. The behavioral health, intellectual or developmental disabilities term is a new term that we're utilizing. It's kind of unfortunately already become overgeneralized. So the idea is that there's a category of individuals who have co-occurring disorders. That's the whole idea behind that term, that individuals are diagnosed both behavioral health and I or DD. So in this situation, what we're finding is that it becomes generalized. We're talking about an individual who has an acute issue right now, who needs to either be entered into HARP or go to the emergency room. In these situations, we just call them we refer to them as a BID individual. Really what we should identify is that this is an individual experiencing an acute situation who is also identified as having behavioral health and IDD diagnosis. So in the whole scheme of things, we're looking at this as a continuum rather than dichotomous. So a traditional rule of thought that we have had out here in mental health and behavioral health in general, as well as developmental disabilities, was that if you're diagnosed with an intellectual disability, a developmental disability, you can't possibly have a mental health issue. And what we found over the last decade is that this assumption is completely false. I think that a lot of the work that was done in the area of autism spectrum disorders since around 2000 or so, 2005, has helped us to see that individuals are experiencing behavioral health issues as well. It's not just a situation where behavior is out of the blue, or we just don't know why they're engaging in these behaviors. We don't understand their history. Move this out of the way real quick, if I can. There we go. Excellent. All right. So moving forward, we have this view that individuals can benefit from behavioral health services and the behavior services, like, for instance, from a behavior analyst. Now, when doing so, we have assumptions. I want you to notice, as I go through these, I want you to notice your evaluations. One of the crazy things that humans can do is we can not only experience, say, a particular rule or a statement, but we can apply our evaluations to it within roughly 400 milliseconds or so. Individuals have unique learning histories that create conditions here now for difficulties. This is an assumption, but we feel very strongly that it's more than an assumption. Safety, security, trust, and comfort have not been consistent for these individuals. A lifetime of this, actually. Experience with trauma is practically not an assumption. Trauma seems to be a part of many individuals' experiences when they are most vulnerable. The aged, children, prisoners, individuals with intellectual and developmental disabilities, and of course, those individuals who suffer from behavioral health issues. Behavior is never out of the blue. Triggers and patterns of behavior are not understandable or predictable. People are people. This is one of those more historical assumptions about individuals who would be considered a BID individual. Poor medication management, which can exacerbate a behavioral condition. Caretakers who are aversive and controlling can exacerbate behavioral conditions. And few people are out there trying to teach communication, friendship, social skills, job skills, life skills, every skills, daily living skills. And I put in here how to pursue reinforcement. That's kind of an odd one, right? We have the capacity not just to go through our days as kind of a leaf in the wind. Or if you're familiar with fishing, a bobber floating on the water. That's not the human experience. The human experience searches. The human experience endeavors. And the human experience thrives and lives off of positive reinforcement. Avoid the bad stuff. Try to find the good stuff. Well, what we're finding, because we have caretakers who are aversive and controlling, what we're finding is because people are not taught communication, friendship, self-advocacy. These are the sorts of things that limit and inhibit an individual's ability to pursue reinforcement, to pursue that valued living, that thing that we thrive on, that thing that makes us feel alive. And over the course of time, this learned helplessness thing happens. You just kind of give up. You don't search for the good anymore. You don't search for love. You don't search for security because it's been found wanting in your life. You don't try. And you end up just simply becoming a leaf in the wind. And so these individuals deserve more than that. Continuing on with assumptions, but different ones. Now this time, notice your thoughts. You may evaluate as well with each of these, but notice your thoughts. Compassion is the foundation and should be the vibe. You might not hear this from very many behavior analysts out there, but I'm a big advocate for energy, the experience. You know, when you walk in a room and it doesn't feel quite right, what do you call that if it's not energy, right? Behavior is energy. Compassion is behavior. Compassionate behavior leads to an energy and experience that is uplifting, that is enabling, that might get you out of the wind if you're just floating and moving towards that stuff that gives you vitality. Perspective taking is essential. All too often I speak with individuals, and again, I've had many varied clinical experiences in my life and in various states as well. And what I'm seeing is that perspective taking is almost obsolete. Now, I know it might be hard to say that you can, with any good sense of competence, that you can know what somebody with an intellectual or developmental disability is experiencing, or someone who is co-occurring might be experiencing. But that's not it, right? That's an empathic type of approach, which does bleed from and leads from compassion and perspective taking. But you've got to have perspective taking where you can at least see that you don't know. Crucially important. Everyone that I speak with when it comes to providers knows what's up. And I've been doing this for 30 years. I still don't know what's up. So let's go ahead and just remove this assumption that we already know. And let's say perspective taking is essential, if at the very least to admit we don't know. Empathic responses, posture is calming events. We also assume that triggers and patterns of behavior are observable, predictable, and sensitive to influence. I don't want to make it sound like we're able to control an individual and make their lives beautiful. Human behavior is incredibly complex. However, if we're aware, if we can take perspective and engage in an empathic posture, we have the potential to identify those triggers, even if we don't know. We'll be able to correlate. We'll be able to look at patterns of behavior across time, because I assure you, it's never out of the blue. There's almost always some pretty good indicators leading up to it. Even if there was only one or two that happened just before a behavioral event, they're still there for us. We're just not paying attention. The prediction is what's important. If you have an individual who engages in behavior in a cyclic event, we need to understand what that pattern is so that we can predict when things are going to get tough. We all experience tough situations, whether it be on a weekly basis, a monthly basis, maybe several months, a year, etc. Humans go through rhythms. We have our natural rhythms. I up and down throughout my time within a month. You know, like today I'm feeling on fire. I feel good. I'm so happy to be here. And, you know, yesterday was feeling, it was good, but it was totally different than today, right? So let's go ahead and accept that our patterns are on cyclic patterns as well, or cyclic cycles. And we're able to identify those. If anything, take moments in your daily life to experience what your cycles are, what your pattern is. If you feel edgy or moody, where did that come from? What was that trigger? We assume that everyone can learn and desires to do so. That should be a capital and. Everyone can learn. It's not the case that a lot of people know about psychology or about human development, and I can accept that. My job and my purpose is to help people understand, not just about patterns of behavior, but that people like to learn. They love to learn. I hated school up until I got into graduate school, honestly. Even university, undergrad was kind of aversive to me. And it's because education was taught to me in an aversive context. When my learning was freed, as often happens in grad school, you're just left on your own to learn a lot of things. I then found a love of learning. I learned how to teach myself, and I learned what it took in order to construct a learning environment. The other half of this that's really crucial that individuals understand is that everyone desires to learn. It just doesn't look like it sometimes. So maybe learning is one trial of folding something, putting something away, saying hello, learning a new word. It can be very small, but we have got to change the perspective here in the state of Missouri, where we actually lean into and create opportunities for people to approach, not put them and require this situation, not to be coercive, but to allow them to approach learning as a cool thing. Of course, reinforcement's crucially important there. We have the assumption that environments that establish learning as a primary value create fun, positive living situations. Let me say that again. When you establish learning as a cultural event in an environment, you're increasing interest, you're increasing approach responses, you're increasing the value of being together. These things that we talk about with our families, but for some reason are lost when it comes to the individuals that we serve and support. We also have the assumption if a person can communicate, they can participate with intention. The most important word here is with, or two words, with intention. It's not just about communicating, right? You don't communicate unless you have a reason. Let's go ahead and help individuals learn to communicate their needs, wants, desires. Let's help them to understand what a dream is. And as abstract as that concept is, that they can touch it in a metaphorical way, that they can plan steps towards that dream. Could you imagine living a life without dreams? We also assume that a person's story can change for the better. When without these assumptions on this second slide, we have no real guideposts for what we should be doing and how we should be doing it. Just taking the first three helps us move forward drastically. Individuals who are diagnosed with a behavioral health condition as well as IDD deserve everything on this page. They also deserve, oops, I can't go backwards very easily, to avoid the assumptions on the prior slide. Oh, how could I forget this one, y'all? I'm sorry. Every single person is worth the effort. And without question, I do know that the greater the effort on the front end, the better the outcomes and the less effort thereafter. So better living through effort is a good general rule to follow, knowing that you will move into a situation where you don't have to work so hard. The effort doesn't have to be so great. You have taught them to communicate. You have taught them to find their own reinforcers. That's incredibly valuable. They don't have to talk to you about the same thing over and over and over again because they have nothing else going on. We've created a learning environment. All right, so how do we do what we do? At the level of the individual, we define, analyze, coach, and evaluate. This is a pretty straightforward consultation model. Behavior analysis in general has adopted this model. So we define what the problem is, and sometimes it's problems. And because we take an interactional approach, we don't just focus on the individual as being the problem or their behaviors as problems. We focus on their behavior in its unique interaction with its environment, which is the provider's environment. We analyze why it's occurring. We got to have data. Don't think for a moment you can look at a progress note and pull all the important data out. What we have to look at to understand patterns of behavior and influences of triggers as well as various other antecedent stimuli, we have got to see patterns across time, and humans love visual stimulation. Make a graph. Make a graph self-graphing where you don't have to get into the computer, just a little pencil mark. Help staff, help individuals themselves understand that pattern of behavior across time. We like to coach others on best practices, on what to do that are best practices based on positive reinforcement or positive interactions in general. And then to evaluate whether what we're doing is working or not. Y'all, I want to share with you, as a clinician, I've been wrong a lot the very first time. I've been right a lot too, so I don't want to make it sound as if I don't have my game on. But when it comes to being a behavior analyst, you do everything you can in that initial assessment to be right. But you're not going to be able to capture everything, mostly because assessments these days have to be very compact, very short, very straight to the point, and let's get to therapy. So what we do in behavior analysis is we treat that initial therapy opportunity as kind of a baseline prime, a continuation of the assessment, making sure we truly do understand the conditions under which things are occurring, because now we're moving things around in the environment in such a way that we're trying to change behavior. That behavior environment relation is crucial. A lot of the things that stimulate our behavior are right here, right now in the environment, whether we can see them or not. Now, how do we do what we do at the provider organization? You might see that nothing has changed other than the term provider organization on this next slide. That's because when it comes to working with systems, which is primarily what my tier team does up until that tier 3 part, we're working with the provider system in order to create better environments for the individuals. So we will define the environment. We will define the problem within the environment, within the system itself. We'll analyze that. We'll coach others on how you might be able to change the system to better provide for these individuals. And then after those recommendations are put in place and our best foot is put forward on them, we evaluate if what we're doing is actually working. Now that's right. Nothing's really different here. Behavior change at the individual level requires change at the level of the systems. There was a great quote that I've carried with me by an individual named Dale Brethauer. He was an organization behavior management specialist. And he said, if you pit a good employee against a bad system, the system wins every time. We can generalize that statement to put an individual who has co-occurring disorders into a bad system. That system is going to bring out the worst in that individual. And so that's why systems change is incredibly important as well. Our focus starts with, what does the organizational system look like? How does it function even? Like, are there units connected together functionally? Do people work together? What are the coercion type situations or coercive situations in general that present in this organization? Let's take out the coercion. Let's take out the aversiveness, because those two things can exist with compassion, with empathy, and with perspective. Our tier 1 works to establish universal strategies with individual organizations. They are the tier that is completely 100% at their level, that being the organizational level. We do work with the individuals within that organization, though, and we're trying to establish universal strategies to help create organizational culture based on compassion, understanding, moving at the pace of the individual themselves, and basically teaching people not to engage in jerk-like interactions. Too often, without even paying attention, we're sarcastic, we're abrasive, we engage in one-upsmanship. We talk about how what they did wasn't as good as what they did yesterday. What they did today wasn't as good as yesterday. This is terrible stuff that we've been exposed to in our lives, and we just perpetuate it unless we're paying attention. Our tier 2 works to identify risk indicators to support providers in gaining access to those services, psychiatry, psychology, applied behavior analysis, and to provide strategies at the systems level for the individuals. And then tier 3 works to identify those who may be experiencing crisis or one or more of the risk indicators. We like to support both the provider organization at this level as well as in the individual. So we might have some targeted behavioral strategies that we can provide. Our efforts. So as I introed with, or relatively close to the introduction, in the world of behavioral health and DD, they didn't really play together till recently. In fact, folks didn't think that individuals with IDD could, in fact, be experiencing behavioral health issues as well. So coming in as Chief Behavior Analyst along with Tier 3, I'm working with Dr. Stanislaus to provide those behavioral supports, to make sure that those individuals in Dr. Stanislaus' pilot project, mostly around the St. Louis area, are supported behavior analytically. Many people do not have behavioral supports services. And so I'm providing both targeted as well as organizational supports along with Tier 3 and under the guidance of Dr. Stanislaus. This is called the DDPSS, or the Developmental Disabilities and Psychiatric Stabilization and Supports. Again, it's primarily being piloted out of St. Louis. And then it's supposedly going to be, after the model is worked out, will be expanded to the state or at least other important areas. We're creating relatively immediate consultation for those who are found to not be in stable situations. We work in unison with the individual psychiatrist and the team to identify the needs for medication management and for behavioral supports. I should put that in there. And what I do is I bring my clinical expertise into the fold, creating that consultation. And if ongoing supports are necessary, I'm willing to provide that. When we have identified the need, we offer the support from all of the tiers, though. This is an important extra little bit of information because when it comes down to it, it's hard to work with an individual who will be experiencing what we call at the top of the triangle, the crisis situations, if the provider organization doesn't have in place very strong, solid, positive behavior support strategies, and that their culture isn't there. So we have actually done full tier consultations with multiple providers over the last several months, where we are identifying what they're missing at each tier level and then providing those supports. We connect with local providers to continue the work because, as we well know, things are cyclic sometimes. We have got to be there to maintain over time. Now, just with regards to initiatives in the DD division of DMH, we have this thing called Pay for Reporting, which we're finishing up our first fiscal year on. We hope to do it for 2 more years. And the idea behind Pay for Reporting is that I'm monitoring what providers who say they can engage in and support individuals who are experiencing intensive needs to provide monthly payments, so long as they tell us how much behavior is occurring and how much is it costing you to support this individual. So for instance, an organization may take an individual who resides in a hospital, in a jail, or who may be unhomed. If they're willing to take this individual, we will pay them every month on top of all of the billing an extra sum of money just to tell us how it went. And it's interesting. You might be like, well, that's kind of weird, just to tell us how it went. Well, the interesting aspect of this is that no one else in the country is doing this. And I want to share with you something that excites me about Missouri and just reinforces the notion of why I came here. We are doing great things in the state of Missouri. We are doing absolutely powerful things in the state of Missouri. Other states, especially around us, see us as being leaders. So we feel like we're going in the right direction, but we're also feeling like, oh, it's 2025. Why doesn't anyone know this already? Well, in this situation, nobody knows, so we have to pay to get the information. That's the first step in what we call a values-based payment strategy. First, you pay for reporting, and then you pay for performance, as I alluded to earlier today. So the idea is that individuals who are experiencing these crisis situations and who live in hospitals, jails, or are unhomed, if a provider is willing to take them, we can get them out of those situations. Some people have been boarding in hospitals for 6 months, a year, year and a half, 2 years, over 2 years in a hospital, taking up a room in a hospital. Isn't that absolutely crazy? Great, thank you for that link there. So nobody really knows in the country what provider needs are. The reluctance to take somebody with intensive needs means that it's going to probably be a loss. Some providers, larger providers, will say that the first 4 months is roughly a loss of about $15,000 to $20,000 before they can start making that back up. And the reason is because of all of the costs associated with individuals with acute needs. Now, in this initiative, we require that the providers organize and create wraparound services, just like the ITRH, so that we're able to make sure that these individuals are receiving all of the support: psychiatry, psychology, behavior analysis. If they need speech and language, that those are brought in as well. So this initiative has finished up its first year. We're starting our second fiscal year at next week, actually, July 1st. And we look forward, we're placing 25 individuals per year. So there's only 25 slots from year to year. It's not cumulative. And those 25 individuals used to live in one of those 3 places. Now they're not. Now they're being supported in the community. And for the most part, people have been really successful. Very happy with this initiative. And then to wrap up, and of course we have time for questions, I want to just in closing share a little bit of kind of what we're trying to do, but also my efforts and my vision. And I like to talk about creating constructional approaches in general, like creating awareness of value in behavioral health being involved in IDD efforts, creating systems that support more difficult presenting issues, creating cultures of acceptance, compassion, and understanding, crucial to our work, creating environments that bring out the best in individuals, creating learning environments and teachers of skills. We're not just giving somebody a place to live. We are literally teaching them how to live, to be, to grow. Creating policy, rules, regulations that remove barriers and establish best practices, expectations. Creating partnerships across all areas. Creating hope for a better day, a better experience, and a better life. And with that, I cannot believe that I did not include a slide that advertised our summit this summer, August 5th and 6th, that's a Tuesday and a Wednesday, in Columbia, Missouri. This is called the Missouri Multi-Tier Systems and Support Summit. We have a variety of providers doing presentations. I'm doing presentations. Our keynote this year, if you know this individual, you should be there. His name is Dr. Patrick Fryman out of Girls and Boys Town, Nebraska. Dr. Fryman has a long history working with individuals and is going to be presenting both a keynote on the first day as well as a breakout session on anxiety. Okay, with that, I'd like to end my slideshow and rejoin you all.
Thank you so much. That was great. And I can say that I've been involved with this BID initiative in Missouri now for a couple of years, and I've learned so much, and it's really exciting to see how much it's taken off. So thank you for your insight and all that information. If anybody has any questions, if you put them in the chat, I'd be happy to read those off. Don't be shy.
Yeah, by all means.
Yeah. We have a few more minutes. I've also put a link for the certificate in the chat for those of you who attended today, and we thank you. So looks like lots of thank yous. Best webinar I participated in. Yay!
Oh, hey, you just made my
Set the
day.
bar. Hi.
Oh.
That's great.
Yeah, I bet folks would love to chat, but it's lunchtime also, so I get that. Let me go ahead and share my screen just real quick. I'm going to leave my email address.
Okay, and this also
we do chat. That's silly.
Yeah, and we do have a good question. How do you work with people who are not native English speakers?
Clinically speaking, my first move is always to find somebody who is fluent in that language. Interpretation is crucially important. So we got to make sure that we can do that if we can do that. Now, I have worked with individuals who are down in Florida. We have a lot of Spanish speaking individuals. And their parents may immigrate into the United States, but their child is the one that might need the help. But in order to work in the context of parent training and parent interaction, increasing their abilities and understanding of what I'm trying to do, I'd literally just pull out Google Translate. I would say what I wanted to say in simple terms, and I would just press translate, and it would slow things down. But it's very important to be able to do that. Now, if that individual can't communicate at all vocally, that's a situation where you would have to decide with the support group, how do we want to move them forward in understanding communication? Now, it's the case that we're living in communities that are primarily English speaking. So it makes sense if the team agrees that you should, in fact, start communication training with respect to English terms, English topics, etc. But if the individual already speaks another language, your best bet is to get somebody on staff who can translate or just slow down. Go ahead and use technology to your advantage. Just recently, I saw that a new bit of technology came out where you can wear earphones that translate on the go. Like as I'm talking, it can translate into another language. And so there's a variety of pieces of technology out there that we can lean on. let's
Um,
see.
I
I'm
think
happy.
everybody's wanting the link, so I posted that so everybody should be able to see it.
And there's my email. If you have any follow-up questions, I'm happy to help out. Let's see.
I'm gonna add your email because it says to host and panelists. So I'm gonna try to copy it in here because I
Okay,
think it only goes to you and me and nobody else can see it. So give me
I
just
see.
uh,
All right, great. I'm here for you. Reach out. I'd love to do another one of these. Could do in person.
yeah,
We could drill down into specifics. This was more overview and high level, but we could drill down into specifics. Just let me know how I could be of service to you all.
awesome. Thank you so much. Thank you, everyone.
All right, you all. Oh,
Thank
and
you.
Jennifer, do we have a
Yeah.
count on today? How many people
There were
participated?
91.
No
Yeah.
way.
Yeah.
Thank
It's
you to
dwindling
91
now,
people
but
who spent your
91.
lunch
Yeah.
with me.
Yeah. Thank you
Awesome.
so much. Thank you.
All righty,
All right.
everyone. Well, if there's
Thank
no other
you.
questions, I'm going to head out.
Okay. Thank you. Have a great day.
Bye-bye.
Bye-bye.